of humility and modesty, which is very appealing for me. She chases the skill in endoscopic surgery with a passion. And also, she has got a very good team in the endoscopy committee. So we are very grateful to her because she has brought up this committee and she has brought up the, the bar for assessment for Kasoga in such a wonderful way. Kasoga is really acclaimed for today for doing very good work in endoscopy and for conducting very good sessions for endoscopy, learning and teaching. And I think in the recent conference, they were all felicitated also by the president of Foxy. So I'm very, very proud of this committee. And you have also chosen the speakers for today very well. Apart from you, I know Rashmi very well. Rashmi also has come up with a lot of hard work, and she has a lot of experience. And also Dr. Rajesh Modi. We have followed Dr. Modi's teachings for so long now, and we are all very eager to listen to him. I must compliment you for the choice of the topics, Prabha, because the topics you have taken today will not only be useful for the core endoscopy, but also for the general gynecologists who many of us are doing some amount of hysteroscopy for infertility, and it is very useful for us also, and hysterolaparoscopy for infertility evaluation. So I'm very well done on the structure of the program, and thank you for having me here. And with that, I request Dr. Durgadas to say a few words, and then you can take this forward. Thank you.
Thank you, Shobha ma'am. I request our president, Dr. Durgadas Sahasrana sir, to please give his presidential address.
Good evening, Kasoga family. First of all, I should congratulate Prabha Desai. From the beginning, the time she has took up, she was very hesitant to take up the chair. I forced her to take this because to keep up the legacy, whatever has been built by the earlier endoscopic committee people. Prabha, you have done wonderful job till now. Your commitment for each month's program and the class of program, the speakers now for national caliber, everything was really absolutely fantastic. And for that sake, I am especially congratulating you for this program. The coin you have, title you have given, Evening with the Endoscopic Experts, it sounds like Karan, Coffee with Karan. It's a very beautiful, beautiful title.
Yeah.
And today's topic, yes, restoring reproductive potential the endoscopic way. You have chosen very good speakers like Rashmi Yogesh, Rajesh Modi, and yourself. Rajesh Modi, I know him personally. I had been to Akola for a few days for endoscopic training with him. I know him as a fantastic surgeon as well as fantastic teacher also. And Rashmi, madam, I am listening to you for the first time. I know definitely Prabha's choice will be the best one. And today's chairpersons, Dr. Bhagyashree Patil, she has been to Tumkur in the last conference as our guest. We were honored. And my own most respected Dr. Vanitha Medgood and my classmate, Dr. Govind Meeraj. With all praises to your secretary, Dr. Priscilla Thomas, herewith I conclude saying all the best to this program. Namaste.
Thank you, Dr. Durgadas sir, for your kind words and your encouragement. We begin a scientific session now. We have the chairperson for the first session, Dr. Bhagyashree Patil. Arun, can you share the CV? Arun?
Yes. Already shared.
Doctor, we are very happy to have Dr. Bhagyashree Patil as a chairperson for our first speaker. She is a director at Kadali City Hospital. She hails from Kalburgi. She's the founder of the Vanch Test Tube and Laparoscopic Center. She's been the past secretary and vice president of the Gulbarga Obs and Gynae Society. She's received various awards by NGOs and social recognition. She's presented various papers at national and state conferences. And we welcome you to our webinar of Endoscopic Committee, ma'am. Over to you, Bhagyashree, ma'am.
Thank you, ma'am. Thank you, me making in join into such a wonderful feast of knowledge, madam. Thank you. And Rashmi Yogesh, she is my friend. We both are UG classmates. I'm very happy to chair her session. And the topic is also very excellent. Rashmi, welcome here. Welcome to the session. To introduce Rashmi, she is my friend as of to say, and she has completed her fellowship in fertility from Patil Fertility Center in 2006, and she has done wonderful work in infertility in Bangalore, and she has become very famous in very short time, and she has made her own beautiful fertility center named Kushi IVF Center, which recently she has opened. It's a dream world of fertility, what I can say. Welcome, Rashmi.
Thank you very much for such a beautiful introduction. And same here, it's a great pleasure to be a part of this wonderful platform. Especially my sincere thanks to the entire fraternity of this organization, which has chosen me here, especially Dr. Prabha Desai. And I know each one of you so well, and I've been an admirer of each one of you who is here. I'm so grateful that I've got an opportunity to be here amidst all of you. Today, I'm going to speak about something that we do every day, that is the hysteroscopy. There is no cycle of IVF that is complete without the hysteroscopy, according to me, but it takes a lot to convince a patient for hysteroscopy, especially when IVF itself is so expensive and they have to spend so much for the IVF. When we tell them about hysteroscopy, the first question that comes is it really required? And most of the times, what actually happens is only when an IVF doesn't work, or when we find that there are some difficulties in doing the IVF per se, it's only then that we end up doing hysteroscopy. But there are a lot of people who know about IVF, they know about hysteroscopy and its importance, and they are people who come asking for hysteroscopy also. However, for an infertility specialist, if at all they're not well versed in the art of hysteroscopy, then it becomes actually incomplete. And therefore, hysteroscopy is a very, very crucial thing when it comes to the entire practice of IVF. Of course, there are a lot of things that one can do with hysteroscopy when it comes to the broader aspect of it. But when it is about fertility restoration and when it is about fertility enhancing, there are few things that are very important, and I would really want to focus on those. Here I start with the presentation.
Arun? Mr. Arun?
Yes, ma'am.
Can you help her to share the screen?
Yes, ma'am. Rashmi, madam. Hello. Hello, madam.
I think she lost the contact and the signals.
Madam, please call her, ma'am.
Yeah, I'm calling her. I'm calling her.
I'm sorry, I was just about to share the screen and I logged out.
You want any guidance?
No, ma'am,
Rashmi?
it's just here. PPT is saved here. Is the screen visible, ma'am, now?
No, madam.
It's not visible. Should I have on this one? I think now it should be visible.
Yes, madam.
Yeah, I think now it will be visible. Yeah,
Yeah.
I had kept the presentation, so I was looking for it. Well, today we're talking
Can
about
you
the
make it a
diagnostic.
slideshow, ma'am?
Yes, yes, sir, 1 minute. Today we're talking about the diagnostic and operative hysteroscopy in fertility restoration and making fertility a much more better thing with hysteroscopy. Hysteroscopy is something that I personally like to do and I'm very fond of it. And the more you do, I think hysteroscopy is something people will start liking it. We know that it is a endoluminal endoscope and mainly meant to visualize the uterine cavity. And a lot of intrauterine procedures can also be done with the hysteroscope. As we know, it started way back in 1869, and we have evidence of several hundred years to prove that hysteroscopy is surely something which is quite safe. And we are very much aware of the instrument, the telescope, the light source camera. We have both diagnostic and operative sheets. And right now, we in fertility practice always intend to use the 30-degree or a 15-degree, especially when we have distorted uterine cavities and we have to look at the ostia precisely. And we prefer using hysteroscopes which have lesser diameter so that we don't have to dilate the cervix. And nowadays, with the advent of 2.9 mm hysteroscopes, which also have the operative sheath integrated, it has become a lot more easier for us to do hysteroscopies without having to dilate the cervix at all. We do several hysteroscopies without even using uh, things like cytolog to dilate the cervix, and we find it very convenient with the 1.9 mm and the 2.9 mm hysteroscopes. Personally, I use the 2.9 mm hysteroscope and find it really useful. And when it comes to seeing the uterus prior to an IVF, or especially when people don't have pregnancies, even with repeated IUI cycles, and not really ready for an IVF, even then we prefer doing hysteroscopy because it also helps in flushing out the tubes, uh, help us do a sonosalpingography simultaneously, and also helps to visualize the uterus. We see that there are a lot of women who conceive post hysteroscopy with an IUI cycle, and therefore I think it can also be taken as a breakthrough between between IUI cycles. We know that when it comes to diagnostic things, we try to look for some hidden infections, hyperemia, micropolyps. We'll look at the vascularity to find out if the endometrium is properly vascularized, to look for adhesions which were otherwise not seen on a routine ultrasound scan, to look for those endometriotic spots in the endometrial cavity which can otherwise not be seen, and also to look for polyps and myomas which looked like polyps myomas on scan, but we really wanted to be sure about it. When it comes to operative, whatever we've seen, we can tackle it at the same time. Polypectomies, myomectomies of submucous fibroids, adhesiolysis, doing subendometrial PRPs to improve vascularity, and several other fertility enhancement procedures can be done. The beauty of hysteroscopy is that both diagnostic and operative can be done at the same time, and therefore it's a diagnostic therapeutic approach in one go. Most of the times when we do hysteroscopy, Even though it is a beautiful triple line endometrium on the ultrasound scan, we will be surprised to look at small things like micropolyps. These micropolyps are usually diagnosed only in hysteroscopy because it's only the big polyps that can be diagnosed in ultrasound scan. Sometimes we see endometrium as a triple line endometrium with hazy margins and we call it as a type A, but we will be surprised to see those as micropolyps when we actually do a hysteroscopy. And sometimes, as in evidence of chronic endometritis, we see layers of micropolyps, as shown in the figure here, which is labeled as B. And sometimes we just see excessive vascularity of the fundus, and we just call it as a hyperemic fundus. But we see that most of these, when we do a culture sensitivity, they yield with some kind of infection. And usually, after this, we see women getting pregnant. However, it could be called as an endoscratch, or it could be called a hysteroscopic effect of increasing the growth factors at the subendometrial layer and increasing the chances for pregnancy. But I also feel having an hyperemic fundus and then treating it with antibiotics is something that can also help in increasing the chances of pregnancy, and it's just not the endoscratch. And sometimes things like tuberculosis, especially when they're in the latent phase, are just visible as hyperemic brown spots. And sometimes we see that the endometrial layer, though is something which is very homogeneous and pink, will have some punctate spots, and these are usually again indicative of infection. And the therapies for infection, what we do in our practice is that we do a simple endometrial culture sensitivity rather than doing tests like ERA, EMMA, and ALICE. And once we do the endometrial culture sensitivity, we treat them with the antibiotic they are sensitive to. And most of the times, with the combo of antibiotics and probiotics, we see that pregnancies do happen. This is not just something that can be considered for women prior to IVF, as I told you, can be a breakthrough between IUI cycles. Of course, when we see polyps, fibroids, most of the times tiny fibroids can look like polyps when we do an ultrasound scan, and it's only when we do a hysteroscopy that we will be able to understand if it's a polyp or a myoma. And be it a polyp or a myoma, hysteroscopic resectoscopes and hysteroscopic uh, yeah, scissors, cold scissors can all result in a proper coverage of these. And we see that even small polyps, sometimes it is difficult, though we have sometimes seen small polyps. And when we do, of course, try excising them with scissors, we see that they start bleeding. And then when we, of course, use a resectoscope or a hook to try and stop the bleeding. And then when we do the histopathology, we get to know that it was not a polyp but a fibroid. Most of the times, despite having a lot of experience, we see that submucous myomas and fibroids, there is always a gray zone in identifying them, especially when they are very tiny. And therefore, I feel hysteroscopy is something that should be considered rather than doing a blind pupil biopsy or a blind DNC when we see things like polyp in a 3D ultrasound scan. And post myomectomy, what we do in our fertility practice is that we try to treat them with contraceptive pills for 1 month, if at all it was a very tiny one. However, we see that most of the times these are all estrogen dependent, and therefore, to help them heal well, we give them HRT. But we make sure we don't give it for more than 3 months because we know that any of these women who develop fibroids and polyps are all very estrogen sensitive, and therefore, we try to restrict the usage of estrogen and try to ensure that we give them HRT but in low dose. We prefer giving them at a dose not more than 2 milligrams, though we have read and understood that when you give high dose estrogen, the chances of developing adhesions is lesser. But what we've seen is that even with 2 milligrams of estradiol valerate, followed by or with overlap of progesterone for about 2 to 3 months, there won't be any adhesions, and therefore we prefer giving low dose estradiol valerate. Sometimes, when we see that there is no estrogen predominance, especially in women who don't have endometriosis, we also give them contraceptive pills. So we are very estrogen conscious when we treat women, especially women who have fibroids and myomas, and more so when they have an element of endometriosis, because we know that the culprit for endometriosis, fibroids, and polyp is all not estrogen, but estrogen sensitivity. And therefore, we try to keep the dose of estrogen as less as possible. The only thing we concentrate on is we ensure that they don't get periods for close to 60 days. If they don't get periods for close to 60 days, then we see that the chances for addition formation are quite less. And most of the times in women who have polycystic ovaries, we see that they have a polypoidal endometrium. And this is not because of excessive sensitivity to estrogen, it is most probably because of the high levels of estrogen they carry just because of not having their ovulation at the precise time. And therefore, we see that the endometrium gets thoroughly polypoidal, and it is not surprising to see women with severe polycystic ovaries having a tubular uterus due to the androgenic influence and have a very thick endometrium, which makes the cavity look really small. We've seen that most of the times the histopathology reveals something called as endometrial hyperplasia, and this becomes a great concern, especially in women who are obese and who don't have regular cycles, and people who tend to bleed heavily. Therefore, in women with polycystic ovaries, it is something which is very pivotal when it comes to trying and convince them for a hysteroscopic guided endometrial biopsy, especially when they complain of abnormal uterine bleeding. We see a lot of women with polycystic ovaries complaining of bleeding for 15 to 20 days, and they get their periods once in every 2 to 3 months. In such women, it is very important to make them conscious about the element of endometrial hyperplasia. Most of those women think that because they did not bleed for 2 to 3 months, that's why there must have been a lot of endometrial deposition and they're just shedding it over a prolonged period of time. Worse thing is that such women are given contraceptive pills to stop the periods, and the estrogen that is there in the contraceptive pills can be something that will be detrimental to their endometrium rather than do good. Therefore, it becomes very essential for us to make them endometrial hyperplasia conscious, tell them about the possibility of a polypoidal endometrium, and then after a hysteroscopy, a hysteroscopic guided endometrial biopsy, histopathology, and treating the hyperplasia is really prudent. And sometimes we just see localized polyps, and especially the polyps that are there at the cornual end, we find them very difficult to kind of negotiate and try to edicialize them, lyse them. That's especially because we are very worried about creating nicks in the corneal area and increasing the risk of forming adhesions at the corneal area. Whenever there are adhesions at the corneal area, there are two threats. One is there could also be adhesions that can spread across the ostia and make that fallopian tube not work essentially well. And the second thing is that because of the presence of adhesions at the corneal end, the risk of ectopic pregnancies also increase. And therefore, when it comes to excising a corneal polyp, it becomes very essential that we exactly reach out to the base of the endometrial polyp and excise just the base without touching the endometrium anywhere. Therefore, I feel hysteroscopy is a procedure that actually needs a lot of patience and precision, and vision is very important. Therefore, what we actually do is whenever it comes to treating somebody who has polyps, and when we have to do a hysteroscopic polypectomy for them, we are very conscious about the fact that we do it in the proliferative phase and preferably put them on contraceptive pills for a short phase till we do the polypectomy, just to keep the endometrial layer thin so that it's easier to perform the polypectomy without touching the endometrium in non-specific areas apart from the base of the polyp. And further 2 cycles, if at all it was just a polyp that we've excised and it's not a polypoidal endometrium, we try and do ovulation induction in the further 2 3 cycles only with letrozole to keep their estradiol levels quite low, and try and do the luteal phase support with dydrogesterone that works very well for women with thickened endometrium. And we've seen a lot of successes in this approach, and therefore we've made this as a protocol in our unit. And post endometrial biopsy for polypoidal endometrium, we ensure that the histopathology is sent to 2 different labs as we see a lot of disparity in the way the hyperplasia is reported. If it is hyperplasia without atypia, we consider treating them with medroxyprogesterone acetate 10 milligrams twice a day for 60 days, and we educate them about the possibility of weight gain and ensure that they get into a weight loss program and an exercise regime the moment they start taking the medroxyprogesterone acetate, and ask them to be very conscious about the weight. We've seen no difference between medroxyprogesterone acetate 20 milligrams per day versus 40 milligrams per day, and therefore we continue to treat them with 10 milligrams per day. And the same thing is applicable here, that we ensure that they don't get their periods for about 60 days. Sometimes, when women deny to take medroxyprogesterone acetate, or in case where the endometrial layer is too thick when we do the hysteroscopy, in such cases, when it is endometrial hyperplasia without atypia, we also consider putting in a Mirena for about 60 to 90 days. However, if we see that the histopathology turns out to be endometrial hyperplasia with atypia, we always refer them to a gynec onco and ensure that they come back to us after the therapy. We do a repeat endometrial biopsy. We usually counsel them for a hysteroscopic guided biopsy. And once the look of the hysteroscopic endometrial layer looks normal, it's only then that we ask them to try for pregnancy. We also look for the endometrial biopsy report, which rules out hyperplasia before they actually try for pregnancy. And the next important and the most difficult thing for us is the endometrial vascularity. There is a lot of controversy about how do we grade the endometrium before embryo transfer. When we look at the endometrium before embryo transfer, some people just look for a perfect triple line endometrium and they call it a day. Whereas there are a lot of people, including me, who also focus on endometrial vascularity, because I feel that until and unless we look at the endometrial vascularity, we're not dealing with a good pregnancy, even if it is bound to happen. The reason is, in our clinic, we have made it a protocol to look at the uterine artery Dopplers even before the lady gets pregnant to be sure that it is within the normal limits. We look at the endometrial vascularity and ensure that the vascularity is there in zone 1, 2, and 3, and even occasional vascularity in zone 4 is acceptable. We look at the RIPI levels and ensure that the levels are within the ranges that we decide should be there during the phase of embryo transfer. We take a cutoff of RI less than zero point 0.9 and a PI less than 2.5 for embryo transfer. And what we look at is a triple line endometrium of minimum 8 millimeters before the embryo transfer. Of course, in resistant cases where endometrium doesn't form at all, with even with a triple line endometrium of 6.5 and 7 mm, we have had pregnancies and we relax our norms then. What we look at is the endometrial vascularity, the RIPI levels. And if these levels are not up to the mark, we counsel them for a hysteroscopy to look at how the endometrium looks like. If the endometrium looks very hypovascular, then we ensure that we treat them with subendometrial platelet rich plasma instillation before we consider an embryo transfer. This is because I'm a strong believer of the fact that a properly vascularized endometrium forms the bed for a proper implantation. And most of the times, we see that women who don't have a properly vascularized endometrium end up either having missed abortions, or sometimes there is a chance of them having low PAPI scores and have high uterine artery Dopplers during pregnancies and IUGR. And that's the reason why we focus on the endometrial vascularity and ensure that we have a properly vascularized endometrial core even before we do the embryo transfer. And sometimes we see that the endometrial layer doesn't come up at all before doing either an IUI or before doing an IVF embryo transfer. In such cases, we are always worried about the presence of adhesions. And of course, if at all with increased estrogen levels, they form pockets of fluid in the endometrium, then we know that there are adhesions inside the endometrium. However, sometimes HSGs do point out towards adhesions and sometimes they don't. Even when we do an ultrasound scan, it's not really necessary that you see those white classical calcific spots on the scan to tell that there are adhesions inside the endometrium. We just see that the endometrial layer doesn't build up and doesn't budge beyond 4 to 5 millimeters. In such cases, we are always worried about the possibility of adhesions and we go in for a hysteroscopy and try to look for adhesions. This is a case where we were never able to have an endometrium beyond 4 millimeters. We could see cervical adhesions and we could also see intrauterine adhesions. Hysteroscopy is a very simple procedure, and when we do hysteroscopic adhesiolysis, we feel very happy if we are able to do a very good job when we cut all the adhesions right from the cervix up to the fundus. And finally, after doing all of this, when we see a cavity which is as clean as this, then we feel really happy about what we've done. So this is a case of endometrial tuberculosis. She was somebody who was treated with ATT 6 years ago, and then she never got pregnant. There were a couple of IVF cycles which were done, and post the IVF cycles, she was told that her endometrium was persistently thin. Hysteroscopy was done. She did not have records of those, but when we did the hysteroscopy, this is what we found, and this is how the final picture looked like. So the hysteroscopic ediciolysis is one procedure which will make the operator feel very happy because the before and after picture is visible within a span of 10 minutes, and it makes us feel really happy about what we do. Post addition lysis, there are several ways of making sure that these additions don't prop up later. Of course, if there is bleeding, you try to do the tamponade with a uterine balloon. We put in a marina. Despite putting marina, we try to give hormone replacement for about 3 months or sometimes 6 months. And the first 2 months, we ensure that they don't get periods. And then we do HRT, ET monitoring to be sure that the endometrium is recovered. And then we start the treatment for conception. Therefore, there are several ways of ensuring that additions don't come up after having done the editiolysis. And after having done the editiolysis, we see that most of the times it is the pale endometrium and additions which look like the endometrium looks completely fibrotic. But most of the times we see that the endometrium is quite thick and still there are additions. This makes things very difficult, especially when it comes to giving HRT, and we try to put in a Mirena in such cases. And now coming to subendometrial PRP or stem cell therapy for an endometrium which is fibrotic or endometrium which is very hypovascular. When it comes to using the platelet rich plasma, it is only the platelet rich plasma which is available to increase the vascularity, and this is what is injected. When we do a stem cell therapy, we just not it is not just getting the plasma out. We're able to get a fraction of stem cells, growth factor, and we also have the plasma. With all of these, there is a huge chance that there will be new vascularization at the endometrial and the subendometrial bed, and the chances for conception will improve because the endometrium also shows a drastic improvement. We had a paper presented in the ASHRAE in which we portrayed a total of about 24 cases, all with Asherman syndrome, hysteroscopic ediciolysis done, and then we did a subendometrial PRP on each one of them. And after 3 sittings of subendometrial PRP and a post PRP hysteroscopic procedure that revealed a normal endometrial cavity, and when we got a proper endometrial core, we found that almost 70% of all these women got pregnant. We found that half of these women definitely had IUGR. They had to take low molecular weight heparin during pregnancy, but they were all able to reach the phase of live birth, and that gave us a lot of confidence about the efficacy of subendometrial PRP. This is a video of subendometrial PRP. We've also done fundal freshening to increase the vascularity. This is endometrial flowing. I'll show it in the next video also. The same video is repeated, so I'll show that next. The next one is about vascular dystrophy. This is a very rare phenomenon, but we have seen in our practice 2 cases of vascular dystrophy till now. It did not look like tuberculosis because it was not just spots. It looked very clearly as vascular vessels, and these vessels were all looking hyperemic, tortuous, dilated, and they all looked bluish to brown in color. This is a rare entity which is called vascular dystrophy. This can be an accompaniment of adenomyosis and endometriosis, and sometimes can be individually seen in cases of endometrial hyperplasia. And what we've seen is that if it is along with adenomyosis, endometriosis, classically textbooks speak about giving OCPs for 3 months, but in our practice, we've seen this as a coexistent thing along with endometriosis. And after having treated them with GnRH agonist depot for 3 months, we did a repeat hysteroscopy and found the uterus to be absolutely normal. and we have had both these women getting pregnant. This gave us confidence that vascular dystrophy can be treated with GnRH agonist depot. And this is the video that I stopped showing then. This is about the fertility enhancing procedures. In our practice, what we have seen is sometimes, despite everything being absolutely fine, we have women not getting pregnant. The endometrial layer comes out well, maybe suboptimum vascularity, but then we have a good triple line endometrium and still women don't get pregnant. In such cases, instead of doing a blind endo scratch, we have the practice of doing something called as endometrial freshening and a subendometrial PRP. So I'll show you how this happens. I think it's the same video. What we actually do is that we just do superficially, we do the freshening of the fundal layer. I think that's here. So we just freshen up the fundal layer, and it's not like we actually excise. We just freshen up, and just the endometrial layer is excised, and then we do something called as endometrial plowing. You can see that it is done bluntly. We just do the plowing of only the superficial layer of the endometrium, and this is done in linear strokes along the anterior posterior wall and the lateral walls of the uterus. Once we do the endometrial plowing, we see that there are stripes of endometrium that are formed, and this what we feel is, after having done this, the stripes of endometrium are very prominently seen, and when we do subendometrial PRP in those areas, it is then that the PRP is able to work better and we have better pregnancy chances with those. So this is a video of the endometrial plowing that we've done. We see that there's hardly any bleeding because we're not going deep inside. We do in all the four walls. This is a lateral wall. So we've done the anterior wall, then the lateral wall. We also do it similarly in the posterior wall. And after having done that, this is about the subendometrial PRP. You can see that we use the same ovum pickup needle that we use for doing the ovum pickup. And then in between the stripes of endometrium where we have done the uh, endometrial plowing, in those stripes, we inject the PRP. And after having done that, we've seen a noticeable increase in the endometrial vascularity. And more than that, we've seen a lot of pregnancies happen. And that has given us confidence that endometrial plowing and fundal freshening is something that can actually enhance the chances for pregnancy. Well, just want to show a small video. This is about one of our patients. What happened in this video is that this lady had a cesarean section, had a retained placenta. Post this, she was advised to go for a hysteroscopic removal of the placenta because of the adherent placenta. And then it was difficult for her to get pregnant because of a persistently thin endometrium. She underwent hysteroscopic edialysis in several hospitals, and then, despite that, her endometrium never improved. When she came to us, we thought of doing a hysteroscopy. When we did the hysteroscopy, we found that the fundus looked completely fibrotic with bands of adhesions. The only difference here, what we did is that we always do hysteroscopy under ultrasound guidance. So when we were doing it under ultrasound guidance, we noticed that the scope was just stopping near the mid cavity. She had an elongated uterine cavity, and anybody would have felt they've reached the fundus if they put the scope in. But in fact, it was not the fundus, but the band of adhesion that was there in the upper part of the mid cavity, which looked like the fundus. So it was a false fundus. It is only because of the ultrasound guidance we were able to make out that this was not the true fundus. So we actually uh, perforated that. It's so difficult that blindly without the ultrasound guidance you can't perforate it. So we perforated that and went inside, and to our surprise we saw a very normal fundus beyond this. That's why I think simple things like this can make a lot of difference. And doing hysteroscopies under ultrasound guidance will give us a lot of confidence, and especially in cases where you have adhesions. Doing hysteroscopy along with ultrasound guidance can give us a lot of clarity as to where we actually are inside the cavity. And post edentiolysis, we can get a very good idea of how the corner and the ostia look like. And until and unless we see the ostia in an edentiolysis, you should not think that you've actually completed doing the edentiolysis. Most of the times we feel that the ostia and corner are completely obscured by adhesions, and that's why we are unable to see them. But until and unless the ostia is visualized, ostium is seen, you should not take it as completion of edentiolysis. This is what I have learned, and I feel it's this is a very major crux in doing hysteroscopic edentiolysis. I think I am done with whatever I know, and I would be very happy if I can answer some questions that our esteemed chairpersons can ask and the audience can pour in.
Very nice presentation, Rashmi. You have included almost everything. One query is on isthmocele, because many previous cesarean patients are coming and cesarean section done at taluka level and very primitive places they are doing and without much good skills. We are in Gulbarga, at least we are seeing many isthmoceles coming with the secondary infertility. Any experience of yours?
Yeah, actually, there are a lot. I think it is overdiagnosed, and sometimes when we see a little bit of collection near the lower part of the uterine cavity, most of the times we see people coming to us with the diagnosis of isthmocele. And what I have seen is that only when you see that there is considerable fluid collection in the endometrial cavity, you should be worried. If there is only a little collection at the site of the so-called isthmocele, we should not be
Yeah,
worried.
what are the symptoms?
Yes, of course, if they have symptoms and if it is a true isthmocele, I feel hysteroscopic resection is something that we've done. But in my personal practice, I've seen that a laparoscopic correction can do more justice than just the hysteroscopic one. We have done hysteroscopic correction for a couple of patients, and we found that it was not as useful as what we could achieve with a laparoscopic correction. And therefore I would not be a very strong advocator of hysteroscopic isthmospheric correction, especially because minor ones are things that need not be uh, treated. If it is sometimes even with a very thin film of fluid in the endometrial cavity, we've seen pregnancies happen. We've also seen sometimes a very thin film of fluid. We can aspirate it, and then I have aspirated the fluid.
And then
Next day,
ET.
the next day I've done embryo transfer and I've still got pregnancies. So I feel a very thin film of fluid should not be the indicator for doing repeated procedures. I feel if it is considerable, then it really needs
Yeah,
correction.
nice.
May
And
I just put one point in this with the permission of chairperson? As
definitely.
isthmocele is a very hardcore topic of mine. See, actually, there is for fertility sake needed, then only we go for laparoscopic correction. If only for symptomatic this thing, and that to depend on the RMT, that is residual myometrial thickness over the isthmocele. If it is less than 3 millimeter, then only we will go for laparoscopic correction.
Laparoscopic. Okay.
If it is less than, it is more than 3 centimeter collection and patient doesn't has any, if it is not too wide enough and there is no free fluid or anything, no need to correct, because so many times we see so many fundal pregnancies with the is niche.
Yes.
Yeah.
Mm. And you have told very clearly about the plowing and fundal. It was really looking very nice. Is there any difference between, we have done a lot of endometrial scratching, only posterior wall we used to do with the hysteroscopy. Any differences have you seen with your practice, Rashmi, by doing this throughout plowing and doing PRP?
I have seen that in resistant cases, when I told about the same thing, that even if everything looks very good on scan, it's a perfect triple line endometrium, everything is good, the vascularity also looks good, but still they don't get pregnant. In such cases, when we do fundal frisioning and endometrial plowing followed by subendometrial PRPs, we've seen pregnancies happen. So I think it is only about awakening the endometrium to produce as many growth factors as possible and increase the chance for implantation, because I think it is an interplay of cytokines and growth factors at the subendometrial layer that will help in implantation, and not just the endometrial thickness and the vascularity. And the more and more we read about endometrial immunopathologies, we see that it's a great effort to increase the chance for pregnancy by injecting subendometrial PRP, which is just an autologous one, which is safe and is not really complicated also. It is something that anybody and everybody can do. We also do a lot of subendometrial PRPs under ultrasound guidance, especially when women can't afford to go for hysteroscopy or are scared to go through hysteroscopy. We use a spinal needle, and then under ultrasound guidance with a full bladder, we inject the subendometrial PRP under ultrasound guidance, and we get almost similar results. But of course, it's always very appealing to do it with hysteroscopic guidance. And when we have 1.9 mm, 2.9 mm scopes, then we are not worried about causing any damage to their cervical circular fibers or the internal os. And that gives us confidence to do it under hysteroscopic guidance rather than just do it under endometrial, do it under ultrasound guidance. I feel this is something that is going to be beneficial, especially for repeated implantation failures.
Thin endometrium is big challenge.
Thin endometrium is mostly, we see that women with thin endometrium will either have a fibrotic endometrium which is hypovascular, or there will be adhesions. Most of the times we end up seeing a cobweb appearance even in such cases, but here we have to do the adhesiolysis, and the same plowing is then called as lateral wall metroplasty because we go a little more deeper. And then the fundal freshening is then called as septoplasty or adhesiolysis, because sometimes we see that the adhesions at the fundus will be visible just like a septum, and only when we start cutting we get to know that it is not the septum but the adhesion. So therefore I feel when it is a persistently thin endometrium, it is usually a scarred endometrium. Until and unless a hysteroscopic intervention is done to do adhesiolysis, and then until and unless we do something like PRP or a stem cell therapy to infuse growth factors and ensure proper healing, and followed by either Mirena insertion or a hormone replacement therapy, it is incomplete. So it's not just doing the operative hysteroscopy and then telling that we have done it. How well we take care of them post the hysteroscopy is also equally important. When we put them on HRTs, as I told you, we prefer putting them on a dose not more than 2 milligrams per day. And we are very conscious about the amount of estrogen we're giving them and the levels of estrogen we are building in them. We feel that giving them high doses of estrogen is not important. Giving them estrogen just enough to make sure they don't get their periods for about 2 months and give enough of time for healing is more important than just give them very high doses of estrogen. This is what we believe. And apart from that, if we do things like additional things, especially if they concentrate on pelvic floor exercises and try to increase the amount of vascularity in the pelvic floor, that is also something that can add upon to the success, is what we believe.
Yeah. Anything, madam? Almost everything Rashmi madam has covered.
Yeah. Any other questions from the audience? I think that was a very detailed discussion. Thank you, Dr. Rashmi, and thank you, Dr. Bhagyashree ma'am, for chairing this session.
Thank you.
Yeah, I think one thing I have not told is about the use of GCSF. People feel it's just not the platelet-rich plasma, but the GCSF addition to the platelet-rich plasma can increase the chances of pregnancy and also help in solving the additions better. But I feel the number of times the GCSF is used is very important. There are a lot of papers that speak about GCSF reducing the chances of PIH, GCSF increasing the chances for implantation. But sometimes excessive use of GCSF itself can cause intrauterine adhesions. Therefore, we have to be very cautious about how much and how many times GCSF is used when it comes to reducing the chances of repeat addition formation. When the whole idea is to ensure that additions don't reform. One is doing addition and second is ensuring that the additions don't reform. This becomes a very difficult thing in several cases, and the persistently thin endometrium is always a very difficult thing to tackle in our practice of fertility restoration. And I feel the success is only when the lady gets pregnant, and we keep the threshold very low. 6 millimeters triple line also, we get pregnancies when the endometrium is being thinner before.
Yeah.
Thank you. Thank you so much for having given me this opportunity. It's been a pleasure to be amidst all of you.
Thank you. Thank you,
Thank you,
Prabha.
Dr.
Thank you.
Yeah. Thank you, Dr. Rashmi, and thank you, Dr. Bhagyashree. I think Dr. Rajesh Modi, sir, is yet to join us. So we'll proceed with the third topic. I would like to invite our chairperson for the third topic,
No,
Dr. Govind
actually,
Mirat, sir.
Priscilla, sir
Huh,
was
ma'am.
little busy till now. He is joining in 5 minutes. I think in 5 minutes I cannot finish my this thing. Till then, we go for introduction to sir and all? Or
Okay, ma'am.
Okay.
Okay, so I'll then we start with the second topic. The chairperson for our second topic is Dr. Vanita Medkud, ma'am. Uh, Let me introduce Dr. Vanita Medkud, madam. She's the medical director of Care Center for Assisted Reproduction and Endoscopy Center at Belgaum Medkud Hospital. She's been a pioneer in infertility and ART with more than 25 years of experience. She's done her training of ART in Australia and Singapore, and she owns the credit of the first test tube baby center of North Karnataka in the year 1997. She's been the founder president of Belgaum Menopause Society. She's also a patron member of the PCOS Society. She's held various positions at Kasoga. She's been the president of OBG Society of Belgaum. She's received various awards to her credit, and it's very lovely to have Vanita Madam on the panel. We welcome you, ma'am.
Yeah.
okay, sir.
Am I audible?
Then, shall I just, your introduction is going on. Shall I just stop it?
Thank you, Priscilla, for the kind words.
Okay.
Okay.
You
Yeah, I'll just give
okay,
the
sir.
introduction.
Okay, sure, sir. Sure, sir.
Just
Sure.
give the
Yeah,
introduction.
yeah.
Okay.
Hello.
A very good evening
Hello.
to one and all.
Sorry to interrupt, ma'am.
Ah, tell me.
Rajesh Modi sir is joining after this lecture. So shall
Is
we
it?
take my
Okay.
lecture and finish off in short
Sure,
and
sure,
finish
sure.
it off?
Sure,
Just-
sure,
Yes,
sure.
ma'am.
No,
Yeah.
you won't need chair for me. Govind sir will share for sir otherwise.
No, Dr.
So then we
Govind,
can
no,
save
go.
the
Dr.
time.
Govind,
We can save the time. There is no
that's
need to
okay.
introduce me, ma'am.
Dr. Govind will be introduced and he will chair your session. Okay.
Madam, there is no need to introduce me. We will start with the third session talk so that we can finish in time. If with your permission.
It's okay, Prabha. Dr. Govind's chairperson will be introduced. Then he will
Okay, ma'am.
introduce you.
Let me invite our chairperson for the third topic, Dr. Govind Mirat, sir. Sir is an well-known practitioner at Hubli. He's done his MBBS from KIMS Hubli and DGO from Ballari and his endoscopy training from Bangalore and Ahmedabad and at France, and his IVF training at Mumbai. He served as the treasurer, secretary, and the president of Hubli Dharwad Gynec Society. He's been practicing in Hubli since the year 1992. He's been a faculty at various state and national conferences. He's a part of the Hubli Assisted Conception Center since 2010, and he's working as the managing director till now. He's also a very active Rotarian and into social services. Um, we welcome you, sir, as a chairperson.
Hello.
Hello.
Govind,
Can you hear
sir.
me? Yeah. Can you
Yes,
hear
sir.
me?
Yes, sir. Yes, sir. We
Yeah.
can hear you.
It's a very short
Ah,
term introduction I request because
yeah, it's okay. No, introduction is not needed actually. Thank you very much for the kind words, and thank you for the opportunity to share this session. Kindly go ahead with your lecture, please.
yes, sir. Thank you, sir. Thank you for saving
No,
the time.
Dr.
Actually,
Prabha needs some
yeah.
introduction, some appreciation
No,
at
no,
least. No. She has
no,
done
no,
a
no.
pivotal
I am not
role
getting
in
this. One
arranging this
second, little one
CM.
second.
Madam, afterward, because Modi sir will join after 10-15 minutes, so he has to go.
Okay.
Sorry,
Okay.
ma'am. We
Yeah,
all are like
sure.
Ritakas.
I
Sure,
said
sure, sure.
my introduction not required. Prabha's introduction, you can go ahead.
Okay.
I said my
Your
introduction no
introduction,
need.
sir, we are.
Yeah.
Uh,
Uh,
whether my screen is see? Hello?
Yeah, it is
yes,
seen.
yes,
Yes.
Dr. Prabha.
It is seen. It is
Yeah,
It
seen.
is seen,
thanks.
ma'am.
Yeah.
Okay,
Yeah, you can
okay.
make it screenshot,
Full screen show.
full screen.
Yeah.
Yeah.
Yeah. See, I just want to finish my talk in before 20 minutes only because it's like keeping the all the budding gynecologists, PGs, and the whoever are doing histoscopy means endoscopy and the fertility practice as a beginners. I have prepared my today's talk with the evidence base for evidence-based management of infertility, and it's a multi infertility is not only one way management, it is a multidisciplinary action is needed for those cases. So we are talking only about the what is the role of histoscopy and laparoscopy in management of fertility. So sometimes it is the only sole factor which will give us a results, but sometimes it is like a added fact. Further procedures are needed after doing the histolaparoscopy. Will come to know when how to go ahead further for that patients. So it is a gold standard for comprehensive infertility evaluation, and it got a significance because not only it is a diagnostic but it is a therapeutic also role, and histolaparoscopy detects a subtle lesions which are missed by the imaging, and it guides the further line of evidence-based management. So this is one short of flow chart when we should intervene with histoscopy. Most of there is no actually duration strategy. You know that after 5 years of marriage or after this much of this thing we should go for histolaparoscopy. But actually the histolaparoscopy indications may be there in the first visit of that patient also. So if initial evaluation and after history taken USG, you will find any abnormality in USG and STG. We are lucky that we can correct them by anatomically with the help of histoscopy, or if it is needed with the laparoscopy. And when there is an unexplained infertility, don't jump directly to the ART or IVF, because so many times in unexplained infertility ART also get failed. So we should know the cause, and with the histolaparoscopy we'll come to know the cause of that infertility, and so many hidden causes will be explained after putting histolaparoscopy, excluding few of like your ovum problem, or there are some fertility issue, fertilization issues or embryo problems. So when to how our decision pathway goes, if even if we are planning for IVF cycle, check the uterine cavity. If it is abnormal, definitely histoscopy has got the role. Check the tubes for hydrosulfings, and before going IVF, we need to block the tube, or we have to take out the tubes if they are more than 2 centimeter in width. Then suspected endometriosis, laparoscopy is recommended if it is hindering your ART management. Then endometriosis evaluation and management is a total different and big issue. But just I will summarize when to go for laparoscopy. In stage 1 and 2, laparoscopy is needed for ablation and excision. And in stage 3 and 4, excision plus fertility planning is has got very major role by laparoscopy. And severe pain or endometrioma for symptom relief, for relief of their dyspareunia and so many other things, laparoscopy is recommended. Previously, laparoscopy was considered as a gold standard diagnostic tool for endometriosis, but nowadays we never tell only for diagnosis put the scope. It is if you are going to operate on them, then only laparoscopy is advised. Otherwise, we can diagnose with so many advanced imaging modalities. So laparoscopy indications being endometriosis evaluation, tubal block or hydrosalpinx, pelvic adhesions, and chronic pelvic pain. And always, if you are doing primarily, then it is always you should have a combined approach with histoscopy and laparoscopy. There is no role of only diagnostic laparoscopy. So there is histolaparoscopy combinedly when we do in cases of diagnostic uncertainty, in short, in case of unexplained infertility, failed treatment cycles, or multiple factor infertility, okay, and IVF planning. How is the outcome? It definitely improves the spontaneous conception in indicated cases, then improves the ART success. It acts to assess the ART success result, reduces the miscarriages, and identifies the subtle region. See, with the experience of these 20 years of fertility enhancing histolaparoscopy surgeries, I just made a to put my this last 4 year 10 months data of about 447 cases which are exclusively conceived only with histolaparoscopy procedures. Okay, they are not only diagnostic, they are all having a therapeutic approach. Like out of 384, if you see combined factors has got major chunk of patients. They are around 384, and out of them 186 become pregnant without IVF. They all have been conceived after intervention with proper planning for their further fertility management, and then they conceived after that. So we should keep this success rate of 29.4% is not less for infertility cases. So there are various modalities of imaging techniques which we use, but there are limitations for that. Like HSG has got high false positive rate of tubal block and of USG may miss pelvic adhesions, and MRI is not an is an costly and selectively we can put patients for MRI only in cases of uterine malformation and dot. See, this was a one small case with very gross PCOD resistant to clomiphene citrate, and when we have done, most of them have previous consultant have concentrated only on resistant PCOS. But when we have done the HSG, we found that there was a bilateral tubal block. And you can see here on HSG, if you read, there was a very filling defect. The two cornea was not completely went up to this. There was a small filling defect. So when I put the histoscope, there was bilateral ostial flap polyps were there. This once we take out the bilateral tubal ostial polyps and then induced her with HMG, FSH and all, she conceived spontaneously. So this is a beauty of histolaparoscopy. So why histolaparoscopy is superior? Because of its direct visualization of cavity, acute tubal assessment, and assessment of ovaries and the pelvis and the adhesions. So actually, sir is going to talk on very elaborately on the tubal factors. So I'm just showing if only on the basis of HSG, if we say that the tubes are patent, we may miss so many of the reasons of not getting pregnancy. So if you have got some doubt on HSG, like a distal tubal dilatation or your HSG, all the while doing ovulation induction and follicular study, your cavity is looking normal, you are getting triple line endometrium. then better if you are not getting the success after 2-3 cycles of ovulation induction, better to do for histolaparoscopy. Then we can get the clear-cut view about it. So uterine cavity abnormalities, just now we have discussed very thoroughly about the role of histoscopy in fertility preservation and fertility maintenance. And this is one of the, it is not rare to see in our society about the chronic retained, post MTP, especially in unmarried pregnancies. So you should evaluate if you get any infertility patients with history of irregular endometrial calcification. There are two DDs, either it may be a tuberculosis or it may be a retained POCs with detailed history of previous, and then with histoscopy we can solve the enigma of that. Then submucous fibroids, of course, fibroid has got again a big issue, but only I want to highlight when to go for histolaparoscopy in case of infertility with fibroids. Septate uterus, this is a complete septate uterus where we can do a unification of cavity by cutting the septum only. Then Asherman syndrome, just now I've seen 2-3 cases. Tubal factors will be dealt by Dr. Rajesh Modi sir in depth. So we are not touching about that. Then these all things are very common scenario. See, always see the undersurface of liver if you have got the PID features, and majority of the cases will have this Fitzhugh-Curtis syndrome positive. Okay, so peritoneal lesions. This is one factor where we will diagnose mainly with laparoscopy, but in very highly specialized MRI expert can diagnose some peritoneal lesions. Otherwise, histolaparoscopy is the main thing for peritoneal lesions, ovarian endometrioma, deep DI and all. Ovarian factors like PCOS, endometrioma and premature ovarian insufficiency. What is the role of laparoscopy in premature ovarian insufficiency? Everybody knows that nowadays there are so many papers which are publishing about the stem cell injections into this PMOF ovaries and getting a pregnancy out of them by getting 1 or 2 ovas. Then this is, see, we always tell that if there are big dermoids, then we go for removal of that. But if you are going for any other workup of infertility, and if you found that there are bilateral small dermoids or adhesions are there, these all we can release, and then we can get a success after removing the pathology of the ovaries. So huge ovarian tumors, okay, and parovarensis, those all will handle your tubo-ovarian relation and make also infertility. So we have to deal with those problems in time and then give the benefit to the patient. So this is also a genital cox. It is very common in Indian scenario. So if we see by ultrasonographically, we'll not come to know this about these adhesions. We'll come to know only about the PCOD. So if put the laparoscopy and then evaluate, release the adhesions and restore the tubo-ovarian relation, and then give AKT, treat the PCO, then that patient will get conceived. Actually, this full video will take long, so I'm just cut shorting. See, this is a case of inflammation associated with PCOD. Never do laparoscopy only for PCO drillings. Okay, there are very few selective cases which need the PCO drilling. If you are going for any other causes of multifactorial causes are there, then only we recommend in case of PCOD cases with multifactorial factorial infertility, then histolaparoscopy is indicated. See, sometimes just now we are seeing the micropolyps very well demonstrated by Dr. Rashmi. Okay, so different, there may be a combined scenario of what Dr. Rashmi has talked just now about the, these micropolyps associated with hemosiderin-like deposits in the endometrium, which both are the features of chronic endometritis. And then recurrent implantation failure, we should know the cause of that. So hysteroscopy is must. Recurrent pregnancy losses. Then when to prefer hysteroscopy? Just now we've seen in depth. Okay. When to combine the histolaparoscopy when you suspect the multifactorial infertility, failed treatment cycle, diagnostic uncertainty, uterine anomalies, and tubal block. See, this is a uterine anomaly which has diagnosed on this thing. If you want to confirm it, this is actually uterine didelphys, but she came with pregnancy after doing 1 to 2 cycles of ovulation induction with confirmation of its factor. And suppose there are patients who came with a abdominal pain with a complex uterine anomaly. So these and with the infertility. This was having a hematosalpinx with a non-functioning functioning non-communicating horn with a very small uterus and the torsion of hematosalpinx. These all things we cannot detect by on imaging modalities, and we cannot correct it also. So such patients, definitely histolaparoscopy will help them to relieve out of the symptoms and give them a further advice of either surrogacy or uterine transplant if they wish. Actually, that patient has come with a acute abdominal pain and lot of uterine anomaly problems. So what ASRM guideline, ISHRE and ICUG, IAG, everybody recommends the histolaparoscopy improves the diagnostic and therapeutic success of infertility. Then endometriotic nodules, if you see, this is a peritoneal nodule. Only I will see this is a ISHRE endometriosis guidelines A to Z. They are very beautifully kept like, mnemonic from A to Z, and majority of this B, C, D, E, F and this K, L, these all are encouraging the histolaparoscopy. You can go through this ISHRE guidelines. They are very wonderful, one line guidelines about one problems associated with endometriosis. If DI and the bowel bladder endometriosis, definitely multidisciplinary approach involving histolaparoscopy. Then cystectomy more than 3 to 4 centimeter of endometrioma preferred is a cystectomy with laparoscopy. And for symptoms of DI, definitely laparoscopy has got role. If less than 3 centimeter of endometrioma, no other any other DI and no any symptoms, then no need of surgery. Then we should use the surgery judiciously. Keyhole laparoscopy is preferred over the laparotomy. Laparoscopy in stage 1 and 2 definite has got a very strong evidence of got improved spontaneous pregnancy rate after doing fulguration and all. Then pain versus pregnancy, decide the primary goal of that patients. If pain is more, surgery is recommended. If infertility is indicated with low AMH and surgery is not absolute, then we can go for IVF. Repeat surgery is discouraged for infertility alone. Okay, IVF is preferred. Then superficial diseases, definitely excision, peritonectomy and restore the anatomy. Unexplained infertility along with the pain with the long duration of infertility, consider for IVF. So for myomectomy, we know everybody knows that all the cavity distorting fibroids has to be taken out. Okay, and more than 4 centimeter to more to 4 to 5 centimeter fibroids intramural with distorting cavity with multiple fibroids altering the uterine architecture and the cavity outlines, fibroid associated with recurrent implantation failure or recurrent pregnancy losses. These all are the indications for laparoscopic myomectomies. Okay, and failed prior IVF and ICSI cases with the borderline cases like more than 3 centimeter, they are not much with near of the cavity like type 4. But having a previous failed IVF and there are no other any causes you could find for the failure, then better to take out the fibroid. Then right now we are discuss about a little bit secondary infertility and the niche. Actually, after correcting niche, not only niche, but about the ventrofix uteruses and adagiolysis, if you do it proper workout and do laparoscopic correction, we are finding the spontaneous pregnancy if this is the only cause for infertility. And ISHRE guidelines, just to sum up, start the infertility evaluation history plus USG, and abnormal USG histoscopy is recommended. Pelvic pain, endometriosis symptoms, laparoscopy is must. Hydrosalpinx on imaging. Before treating for IVF, go for laparoscopy and do the delinking if it is more than 2 centimeter and filled with fluid. Recurrent implantation failure, do histoscopy. Unexplained infertility and young age, it is considered as considered for laparoscopy. Multiple factors, definitely combined histolaparoscopy is indicated. These all are outcome of the work what we have done. And thank you one and all. Hello.
Yeah.
I think I finished in time.
Yeah, that was a very, very nicely put, a very nice presentation. I congratulate you on this presentation, and I also apologize for not introducing you at the beginning.
No, sir, no problem, sir.
Everybody knows that you are a very good endoscopic surgeon in this part of the state and doing wonderful work. And very recently, you organized a very great conference also in Gadag, and you are conducting this wonderful webinar series in endoscopy. One thing, when patient comes with infertility, what you decide is whether which patient really requires an invasive investigation like endoscopy, laparoscopy, or histoscopy. And as you said, the ASRI guidelines, if you can investigate in those guidelines the infertility patient, definitely you can differentiate which patient really needs laparoscopy and histoscopy we don't require. Patients coming with dyspareunia, patients coming with dysmenorrhea, patients coming with bilateral tubular blocks and HSC, patients having more than 3 years of infertility, definitely they are going to be benefited by laparoscopy. And when you put in a scope, definitely you find either a stage 1 or stage 2 endometriosis or some tubal adhesions, and these things will decide. And also in histoscopy, take help of 3D ultrasound, which can avoid many times the early stage histoscopic procedures, because almost it is complemented to histoscopy, and most of the simple things can be diagnosed with 3D ultrasound.
Yes,
so once again, I congratulate on this wonderful presentation. Thank you very much.
Sir.
Thank you, Kasoga, also for giving me this opportunity to share this session.
Yeah. Thank you for this small, miscommunication. I'm sorry for that miscommunication, and thank you for chairing my session, sir. Actually, little bit, that work pressure and making this presentation, I missed communicating with sir on starting
you have done a wonderful
webinar.
job. You have put all things in a very nice perspective.
Thank you, sir.
Ma'am, what is your take on using the tubal catheter to flush the tubes during hysteroscopy?
Not for every case. Only if you are, don't do unnecessary these things. Only if you are having that adhesions and if you want the corneal cannulation, that time only. Not for every case. So I think sir will be the waiting for his talk. Can you just go ahead for?
Yeah.
Has he come?
Yeah.
Has he arrived? Okay.
Yes. We request Dr. Vanita Madam to please chair the session, and we have Dr. Rajesh amongst us as a speaker.
Okay. Very good evening to one and all. At the outset, I congratulate the entire Kasoga team for their wonderful work being done, led by Dr. Durgadas and Dr. Shobha Gudi, and a special mention to Dr. Prabha, who has a pivotal role in organizing this endoscopic committee webinar series. And I can say that she has done revolutionary work in Gadag, because the way back I was invited by IMA about 10-15 years back, no one was doing laparoscopy in Gadag. So I have a great appreciation for Dr. Prabha, who has started this laparoscopy work in a place like Gadag. So now coming to today's, the theme of today's webinar, restoring reproductive potential, is very apt, and endoscopy is the right way to do for many benefits like precision and perfection. Restoring the fallopian tube, not only its anatomy, but the physiology is a big challenge since it has a crucial role in fertility. And to deal with challenging topic, today we have with us Dr. Rajesh Modi, the expert in the field of endoscopy. We are eager to hear and see your skilled work, sir. The topic, tubal evaluation and restoration and the endoscopic way. Can I have, yeah, his, uh, the,
Yeah, very
Dr.
thank
Rajesh
you
Modi is
for the
a
nice.
pioneer in gynec endoscopy, and he doesn't require introduction because all know about him. I myself have witnessed many surgeries like he has simplified laparoscopic hysterectomy as a daycare surgery, and one more about the micro dissection, hydro dissection for myomectomy. So he is a renowned senior gynecologist and endoscopic and robotic surgeon at Akola Hospital at Akola, and he told about the care laparoscopic hysterectomy and the lap myomectomy, which is almost a bloodless surgery. And he has conducted fellowship and short courses for gynecological endoscopy at Akola and in India, where he's a director of Kola Endoscopy Center, and he's a consultant at the Anamati Hospital in Mumbai, and Seven-Star Hospital in Nagpur. Apart from his expertise in the field of gynecology, Dr. Modi believes in sharing and mentoring the budding young minds with live surgical streaming on Facebook. And his live surgeries are available on a podcast, and the address is also given. Many must have already watched, and it is really a pleasure to listen to him and see his skilled work, sir.
Vanita,
Dr. Rajesh,
yeah,
yeah,
so
I
much
welcome for your presentation.
welcome. And be talking his tubal factor. I will be screen.
Please share your slides, sir.
Yes. So I'm going to be able to see this.
Sir, your voice is breaking, sir.
Just hold. See this.
Hello.
Are you able to hear?
Yeah,
Sir,
we are
it
able
is
to see the
breaking.
video, sir. Hysteroscopic video.
Yeah. Typically, when tubal can is placed.
Sir, your voice is breaking. I think some internet problem is there. Hello. Hello.
Are you able to hear me now? Is this?
Yeah, yes, sir.
Yeah.
Yes, sir.
Sorry about the interruption. I changed my internet connection. So I am talking about the tubal factors in infertility and whether laparoscopy and hysteroscopy is going to be of some relevance. So obviously, as far as work is concerned, operative work is concerned, cannulation is the most easiest and commonest performed tubal surgery or recommended as a surgical correction of the tubal factor. So tubal block, if it is a mucus plug, then it can be flushed open. If it is a damaged tube which is adherent, then it cannot be flushed open. So at least the mucus block part should be opened. Now, tubal cannulation, the movement required is only pinching the tube between the thumb and the index finger and rotating a little bit. So hand-eye coordination or surgical skill required is not significant. All you need to do is thread the catheter in the ostia, 1 or 2 millimeter inside the ostia, the tubal catheter will go, and then you flush the tube open. Again, surgical expertise or the surgical skill required is only to be able to toggle the catheter between the tip of your thumb and the index finger while doing hysteroscopy. So the amount of expertise required is not much. Anybody who is doing basic hysterolaparoscopy work is able to do the tubal cannulation and to retreat. Only if it is a mucus plug or a very simple block of the tube, which can get flushed open by the pressure exerted when you do this selective tubal catheterization and flushing of the tube. Those tubes are healthy enough to be actually opened and then to have proper intrauterine conception. Earlier, in the first 1 decade, from 2001 to 2010, we used to pass a glide wire, metal glide wire, soft glide wire from the catheter and make sure that the tube is opened up and the dye is coming out from the femoral end under any circumstances when we were doing hysteroscopic surgery or cannulation. But we realized that most of those patients either have a repeat block or a very high chance of developing an ectopic pregnancy. So then we stopped doing that passing of the glide wire or trying to open up under any circumstances kind of a scenario. Simple flushing, if the tubes open, they are healthy tubes, the patient can try in for natural pregnancy. If the tube is not opening like this by a simple flushing, then better to not go ahead and forcibly open that block, because the tube, that means, is inherently unhealthy and it is likely to go in for an ectopic pregnancy. So from tubal surgery perspective, the primary surgery what is recommended nowadays is the hysteroscopic tubal cannulation. Obviously, you need to put in a laparoscope from above to see whether the tube has actually opened and whether the dye is coming from the femoral side or not. Kindly allow me a minute to share the next video. So are you able to see this video now, the new one?
Yes, sir.
Yes,
Yes,
sir.
sir.
So here you can see that the tube is quite bad. So in this case, when you try to flush open the tube, you may be able to pass the dye into the tube, but there might be a lot of extravasation which happens. So in a bad case, do not make much of an effort to open it up. Here you can see that the cavity is also slightly distorted because of adhesions. We have done some basic adhesiolysis in the cavity. And now I'm going to see whether the tubes are likely to remain open or not. So these are a few of the earlier videos. Like I mentioned, we used to make a lot of effort, make sure that the tubes remain open at the end of surgery, because patients are very keen that once they have posted for a tubal surgery, the tube should open up. But now when I am posting the patient, we are very cautious and we guide them before the surgery that if the tube is healthy and they open up comfortably, then we will recommend that you go in for a natural pregnancy. If the tube is not healthy or if the tube is blocked, like this one, you can see that there is a lot of extravasation. I'm struggling at the femoral end doing adhesiolysis. So even if the dye comes out from the femoral end, this is not going to give you any fruitful end result. The extravasation implies that the tubes are quite bad. Future chances of ectopic pregnancy in a patient like this is very high. So this is what I meant when I said that don't force the tube open, don't make too much of an effort. If the tube is opening with a simple flushing, that is fine. Otherwise, give up on it. So this is the primary surgery which we recommend. Now, apart from this, there are a lot of other situations where you would like to go ahead and do the surgery. Sorry, 1 second. I'm trying to open the next one.
So do you recommend for this kind of tube to be taken out on the at the site, or you want to leave that tube there?
So if you have already counseled the patient that, okay, you can do a salpingectomy, if the tubes are very bad, then you can consider. But otherwise, a patient of infertility who has been posted for tubal cannulation, you would be very hesitant in trying to counsel the patient that, okay, we have now removed your tubes. Sorry about this. So now this is the second commonest from the laparoscopy point of view, ectopic pregnancy. So earlier, again, what we would do is if the patient has come with an ectopic pregnancy, this is an unruptured ectopic, tubal ectopic. So I would open up the tube, not use current, and make sure that we are not leaving any ischemic area inside the tubal area. Remove the ectopic part. By using vasopressin in the broad ligament, you can skip causing any ischemic trauma to the tube. This is only the serosa part which I have opened yet. The tube has not yet been opened. So this is the tubal surgical part. So tubal surgical part, apart from cannulation, is either for ectopic pregnancy or for hydrosalpinx or for tubal recanalization. So here you can see I am gently opening the tube. The anti-mesenteric border can be opened and then the pregnancy or the ectopic part can be cleared off completely. Because I have used vasopressin over here, the amount of bleeding is insignificant or very minimal. There is no need to touch with a cautery. We have removed the tube, do a gentle suctioning within the tubal area. And here I am not suturing the tubal part. I am only covering the serosa on the tube. The tubal thickness or the mucosa and the serosa of the mucosa or the muscularis of the tube is going to be friable and fragile. So you can leave it alone, and I'm closing only the serosal part. If it is going to heal, it will heal. You do an HSG after 3 months and see whether the tube is having a block or it is healthy enough to be attempted for a future pregnancy. Now, obviously, any patient who has developed an ectopic, the subsequent chances of developing an ectopic are definitely on the higher side, but you have to be able to balance it out. You have to be able to figure it out that whether you want to try and give this patient a chance, or you would rather recommend for test tube baby or IVF. Because if patient is educated enough and they are keen enough that, okay, the moment they miss their periods, they will get a beta HCG done, an ultrasound scan done, and in case of an intrauterine pregnancy, they can definitely continue. So option is available. But as you can notice that this is quite an earlier video with a single chip camera. Now we don't recommend this. Now any patient coming with ectopic, we straight away recommend that we will do a salpingectomy and the patient should go in for an IVF. Conserving the tube in an ectopic pregnancy is what I did for almost 1.5 decades, but then I have stopped doing it. Let me open the next video. So that is one important aspect which you can consider as tubal surgical part, that in ectopic, whether you want to conserve the tube, if you may not do a repair, but even if you just simply open the tube and leave it as it is, that also will be fine enough. I'm so sorry. I'm just going to stop sharing and open up the correct video. Kindly give me just half a minute. I'm trying to...
So do you have a video of hydrosalpinx?
Yes. I am
So
actually...
when to conserve, when to excise?
Yes, I am a little discoordinated right now. So I was... Yeah. So I do have a couple of videos for that purpose. This is for the recanalization part. So we have done a lot of tubal recanalizations. Again, the concept which I have is for any tubal surgery or any ovarian surgery, I use vasopressin in the infundibulopelvic like this. You inject 10 units of vasopressin is diluted in 100 ml of normal saline, and maybe 15 to 20 ml of that solution can be injected into the infundibulopelvic area like this. Once you inject into the infundibulopelvic, there is absolutely no need to touch anywhere with the cautery. Because this is a recanalization procedure, there is a little bit of vasopressin being injected onto the corneal end also. It was not only in the infundibulopelvic area, even in the corneal area, I am trying to inject the vasopressin. So both the ends we are covering with the vasopressin. Vasopressin causes severe vasoconstriction temporarily. And then we freshen the edges of the tube only with a scissor. No energy source to be used, neither monopolar nor bipolar nor ultrasonic use. Just simply cut off the ends which are fibrosed. By simply cutting off the fibrosed ends, the freshened edges are not having any ischemic impact. The healing of the tube after suturing is far better and superior. So here you can see I am cutting open the medial end of the tube. So the bulge is because we are injecting the dye from below. The tube appears a little more white because of the vasopressin which has been injected. So this is the tube which is opened up. You can see that the vasopressin was coming out from the methylene blue was coming out from the medial end. The lateral part of the tube also needs to be reassessed. So from the fimbrial end, we are pushing the dye. The ampullary portion is bulging up, and I am freshening the edge of the lateral half of the tube. So this is, like I mentioned, the main advantage is we are not using cautery or current. So there is no ischemic damage to the tube. And I prefer to use 6-0 vicryl. 6-0 vicryl is used to suture the tubal end-to-end anastomosis. This is the first stitch on the mesosalpinx so that both the ends of the tubes are brought together. Invariably, there is a lot of luminal discrepancy which we encounter. Most of these patients have tubectomy done with mini laparotomy. So the segment of tube which is removed is a bit more than what we expect. And invariably, the medial end is narrow. The ampullary portion is quite wide. But my experience in the last 10 years has been, even if there is a luminal discrepancy, the chances of having an intrauterine pregnancy are quite high because the mucosa of the tube is healthy. See, luminal discrepancy, the main worry is that whether the ovum will get stuck at the location where there is a luminal discrepancy. But somehow it doesn't create any problem. I have not encountered an ectopic pregnancy in any of my patients who have undergone a laparoscopic recanalization at my place. I do an HSG at the end of 3 months. And I fortunately have a very high tubal patency rate on HSG, which is almost 90%. The pregnancy rate is 50%. So out of 10 cases on HSG, 9 may exhibit a tubal patency, but hardly 5 of them conceive, 5 of them don't conceive. But I believe even that is quite a high pregnancy rate. So here you can see what I am doing is simply burying the narrow end in the larger mid-ampullary portion. Whatever is available, I do end up repairing it. We don't leave it because of the luminal discrepancy. And obviously, HSG will show patency because from a narrow tube into an ampullary portion, the dye flows freely. The fibrosis will not hamper or block the tube. But pregnancy rate is definitely less than what we achieve as a tubal patency rate. On table, all these patients will exhibit the dye coming from the fimbrial end. And I do both tubes at the same time. So we do a bilateral repair of the tubes whenever we do a recanalization on table. Like I mentioned, we have patency which is demonstrated on table for almost every patient. Only 3 sutures are sufficient: 6 o'clock, 2 o'clock, and 10 o'clock. I don't believe in a watertight closure. Invariably, the serosa will heal, even if it appears that there is leakage of dye which is happening from the anastomosis. As long as there is some dye coming from the fimbrial end, we are happy with the end result. So tubal recanalization, the amount of recanalization which I have done in the first decade is quite high compared to now. Now we don't really end up doing a lot of recanalizations because I think most of the patients, they prefer to go in for IVF, and even I do recommend that they should go in for IVF. It becomes a little more simpler for them to achieve the pregnancy. The tubes are healthy, that is true, but still, in spite of that, if you try to do a recanalization of a patient, the chances of ectopic are higher compared to that because the uterus is healthy, the tubes are healthy. The chances of the patient conceiving in a first or a single cycle of IVF is equally higher. I'm just trying to open up the video for what I need to talk about as far hydrosalpinx is concerned. Kindly give me a moment. So this, what I'm sharing now, is a hydrosalpinx, not a severe hydrosalpinx, a mild or a moderate hydrosalpinx, you can effectively open up the tube and you can presume that there will be conception happening. But anyways, again, the chances of going in for an ectopic are always there. So same concept. No, don't use current as far as possible. Use vasopressin in the infundibulopelvic area, and then the vasopressin injection needle going parallel to the vessel. Just below the peritoneum, you can see the bevel comfortably. 10 units of vasopressin diluted in 100 ml of normal saline. 15 to 20 ml of that solution is injected over here. And that much amount is sufficient for this particular tubal surgery for the hydrosalpinx. If the tube has a lot of adhesions, then I'm a little more reluctant to operate on that tube. In a case like this, where there are not too many adhesions, the tube is blocked, there is a mild hydrosalpinx, I would perhaps attempt a cuff salpingostomy and hope that the patient conceive. Incidentally, this particular patient, which I'm showing here, this one did achieve an intrauterine pregnancy. So we have injected vasopressin, the fimbria is bulging when we are injecting the dye from below. The serosa is opened, not the tube yet, only the serosa has been cut open. And now I am cutting open the tube. This is a tubal part which has been opened. The ampullary area is bulged out. Once the tubal part, the ampullary part is bulged out, we roll the ampulla back on itself like you are rolling a sleeve, the shirt sleeve. Now, if you simply roll this back and leave it, probably it will close again. It will unroll itself and it will close again. So to make sure that it stays in this particular rolled up position, same 60 vicryl we are using to take two sutures, one at 3 o'clock and one at 9 o'clock, and anchor it to the serosa of the tube. So this will not close again. A little easier compared to doing a recanalization. And two sutures are sufficient, 3 o'clock and 9 o'clock. Like I mentioned, this is only to ensure that the tube remains open even after the surgical work is completed. Otherwise, there is a high chance that after some time the tube will close on its own. Vasopressin really works beautifully in all adnexal surgeries, whether it is tubal surgery or ovarian surgery. And there is no rebound bleeding which happens once you have finished the surgical work and once the effect of vasopressin has worn off. There is no rebound bleeding effect, so don't be worried about that part. Again, taking a simple bite into the peritoneum or the serosa of the tube. This anchors the opened out tube on the tube itself. Once you are comfortable with laparoscopic suturing, even tubal surgery becomes very easy to do. The main thing which we are worried about is the cut through which may be happening. So this is what I wanted to share about the tubal surgeries. I hope this has been sufficient and quite up to the mark what you had expected. The commonest surgery to repeat again is the tubal cannulation, which can be done for simple blocks. It is the effective one. The other three things about the ectopic, about the hydrosalpinx, and about the recanalization, nowadays the outcome plus the chances of ectopic make it more in favor of advising the patient to go in for an IVF. Thank you for a patient listening.
Sir, can I ask one question? What
Sure.
is your this thing about that pellet like making the four pellets of petals of this while doing fimbrioplasty and
So,
cruciate incision, taking cruciate incision over the blunt end of the fimbria and then taking each separate as a petals of flower and then everting them. Whether that will have got any advantage over this technique?
from the purpose of
Hello? Hello?
Sorry, am I audible now?
Yes, sir. Yes, sir. Yes, sir.
Yeah, so because
Sorry.
I was doing a screen share from my computer, I have logged back in from my mobile. I was
Okay.
not able to have my own video coming in on the computer. So what you're talking about is another method of doing a tubal surgery. The cuff salpingostomy is adequate for mild hydrosalpinx. If it is moderate to severe, then you can do the cruciate incision and then anchoring it back. That is fine.
Any
Both techniques.
criteria of that, how much width of the hydrosulfing tubes we should consider for sulfing fimbrioplasty, and how much means size of the tubes we should cut off
No, from
before
my
doing?
perspective, rather than the size, I look at the peritubal adhesions. If there are too many adhesions, then I'm not happy with the infection in that area. Infection causes adhesions. So if there are too many adhesions, then I'm not happy with that, and then I would not want to open that tube. If there
Okay.
are no adhesions, like the one which I showed just now, there were no peritubal adhesions. Then in that case, I would be happy to go ahead and do a cuff salpingostomy or any fimbriectomy, fimbrioplasty, so that the tube can open up. So more than the size of the tube, what would be relevant is the healthy situation of the tube and the peritubal area.
Yes. Means we used to read on that more than 2 centimeter width of the hydrosulfings don't preserve the tubes.
Correct.
Just take off. That's why I was, because so many of we are finding that so many of youngsters are just because of hydrosulfings, they are taking out the tubes very frequently, and they, there is no other options for the patients to go for
IVF, yes.
other than IVF. Yes.
So any other prognostic factors to decide salpingectomy and conservation?
See, nowadays, no, even though I am skilled in the tubal surgical part, my own opinion has been that if the patient can be okay to going for IVF, I would recommend that rather than doing a tubal surgery, I would post them for an IVF cycle. The chances of ectopic are very high in these tubes.
So, but if we treat the cause of that disease also, it may, give a better chance to the patients. No? I think this will be a big debate. Otherwise,
Yeah.
yes.
If Prabha, if it is already damaged, that cannot be reverted,
And I mean, if there
isn't it?
is less damage, like what sir has shown in the last
Minimal.
video, might be if we, it looks like it cocks. If we take the biopsy and it turned out, and if we give AKT, she may. Because 1 or 2 such pregnancies I have found after doing fimbrioplasty for that much size only, not too big, but like a tubal block with a tobacco pouch appearance and all. If you do fimbrioplasty, they conceived. But with prior explanation of all those consent and all the chances of ectopic and all, only we'll go ahead. But
Yes.
as sir said that with explaining all those risks, also the patient so many times they are not willing for taking out of the tube.
Yes, because that
Yeah.
emotional part is something
But
which they are not
for
willing for.
those patients, category of patients, we can keep this tubal surgery as an option and then give them a one chance in their life. Sometimes they get conceived also with
Yes,
AKT and all after that.
very true, very true.
So proper
Sir,
counseling is mandatory. Yeah.
Yes.
Okay.
so your take on if you see badly adherent tubes to the posterior surface of uterus, would you remove them or would you just clip or tie them up?
Bad or damaged tube, depending on again what level of counseling has been done. If it is patient who's leaving it entirely up to me, I will tell the patient that if I feel that the tubes are quite bad, I will go ahead and remove the tube and we will directly go for IVF. If the patient has that much of faith in me, then I would prefer to do a salpingectomy rather than only unclipping of the tube.
Yes, sir.
Then post a medical treatment of ectopic pregnancy, do you prefer a HSG or a hysteroscopy?
HSG is a better option first because you haven't had an ectopic, the patient has responded to methotrexate and you want to assess whether that tube has become blocked or it is still patent. HSG would be required. Hysteroscopy would not play much role in that context. Unless you're doing a hysterolaparoscopy, then probably then you would want to put in a scope and see everything.
Yes.
Yes.
Actually,
It was
So
an
there are
excellent
some
presentation.
questions from the audience.
Yes,
It's on the chat. So what care is to be taken to save ovarian flow during salpingectomy?
You remain flush to the tube. When you are doing a salpingectomy, if you lift the tube up properly, you can see that there is a web of vessels just below the tube, and there is a web of vessels which is close to the ovary. Now, if you are going to cauterize significantly, then that ischemic effect goes to the vessel or the web of vessels towards the ovary also. So very particularly, if it is a young patient and I'm doing a salpingectomy, I make it a point to lift both end of the tubes with two graspers and then use the bipolar or the thunderbeat to cut close to the flush to the tube. So ovarian vessels should not be affected. That is sufficient. Nothing beyond that is required.
Yes. So have you come across any cases of post-salpingectomy, like post-pregnancy, post-IVF pregnancy and all? The sometimes there is a stump that remains.
Yes,
The salping.
See, this
Have
is
you come
very
across
basic.
cases of complications of the stump of post-salpingectomy?
No, not yet, not yet.
See, while
Prabha
taking
ma'am, in your
no, I have come across of others with stump ectopic, which has been already done a ectopic surgery somewhere outside. They have left the, partial salpingectomy is not recommended. You have to go up to the cornea, and then this is very basic of a salpingectomy actually technique. But still, somebody will leave that part of the, I don't know, affected where the ectopic pregnancy is there. That much part only they will cut off. But that is not the ideal thing. You have to go till the cornea and then cut the whole length of the tube. Then you will not come across such stump ectopic. But I have come across one patient with stump ectopic.
do we have any other questions from the audience?
Oh. It was an excellent presentation, Dr. Rajesh Modi. We are really, it was a great pleasure watching your skilled surgery. It comes so smoothly, especially that ectopic pregnancy. So gently you were removing. It's a God-given skill, I feel. And by practice, one can do it.
Yes.
Yes, sir.
Thank you very much, sir, for the
I'm also
today's,
thankful to all of you for this wonderful opportunity and for the interaction. Thank you all. Thank you, Dr. Prabha. And it's really been nice to be there with you all.
So I'm extremely sorry. Actually, there is
No
some
issues.
miscommunication has happened,
No issues.
and I was not intended. I have in my back of mind that I would send everybody gentle reminder, and
No
extremely
problem.
sorry for
No,
that
nothing like that.
miscommunication.
Don't
Yeah.
feel bad about it. Happens. No worries.
Yes. Yes.
Right. Thank you all.
Yes.
I'll
Thank
take
you,
care.
sir. Thank you. Thank you
so
for
Thank
that
you, sir.
website,
guidance. Yeah. Thank
okay,
you, madam.
that website you can just tell to others, sir.
It's now
To
mainly YouTube. No, YouTube, you search for
YouTube,
my
you
name.
search sir's name, you will get a
Videos are
Yeah.
there. All my
Yes.
unedited surgical videos are uploaded on YouTube. Even recanalization surgery is there. And YouTube is more easy than watching on the website nowadays.
Okay.
Yes.
Yeah. Yes.
We should thank you for all the videos that you have put up unedited, sir. Your videos have made us learn a lot. And then when we see your videos, they seem very nice and easy. And then when you start doing it, you remember that you've seen only Modi sir's video, and it's you who are doing, so you'll have to struggle that. But big
That's
thank
true.
you, sir, for putting up all the unedited videos.
My
And
pleasure. My
actually,
pleasure.
sir, you are, like for us from our PG period, we are seeing you are all those in journals, that histoscopy, that lady
Yes.
Yeah.
Take care.
Hysterectomy patient. Yeah.
hysterectomy patient holding one bag, and that is like, really this thing that he should also become a one day, daycare surgeon for like Modi sir. So really you made my day, sir. Thank you for your very cooperation and your consideration, sir.
My pleasure.
Yes, thank you, sir.
Thank
And
you. Good day.
the time you shared,
Okay.
in spite of your busy schedule.
Right.
Yeah.
Good day.
As we conclude our session, I would like to first thank our chairpersons, Dr. Bhagyashree Patil, Dr. Vanita Metkud ma'am, and Dr. Govind Mirat sir, for sharing your valuable time and chairing the sessions. I would like to thank all our speakers, Dr. Rashmi Yogesh, Dr. Rajesh Modi sir, and Dr. Prabha Desai madam for their valuable inputs. It was indeed a very good discussion. Thank you, Dr. Durgadas Asrana sir, our President Kasoga, for giving Endoscopic Committee this opportunity. And thank you, Prabha ma'am, for every month coming up with a very innovative topic and, motivating a lot of gynecologists in, moving forward into their endoscopic journey. Thank you all the participants for, making your time and attending the session.
Thank you, Prabha.
Thank you, everyone.
Yes, thank you, ma'am.
Thank you.
Thank you.